From ASTMH 2022, this is TWiP, This Week in Parasitism, episode 210, recorded on November 2nd, 2022. I'm Vincent Racaniello, and joining me today here in Seattle, Washington, Daniel Griffin.
Hello, everyone.
Not in New York. Nice to see you here in Seattle. Also joining me here in Seattle, Christina Naula.
Hello, nice to see you all in person, not in Glasgow.
You've come a long way, right?
I have come a long way,
How many
yes.
hours flight is that?
I think it was 9.5 hours.
Wow.
Direct, so quite a long time.
And we have a guest from this meeting. She is a professor of family and community medicine at the University of Toronto and clinical director of travel medicine at MedCan. Aisha Khatib, welcome.
Thank you so much, Vincent, for having me.
Our pleasure. And you're at this meeting, and we have grabbed you to talk a little bit about your career and your work. So thanks for doing that.
Thank you so much. Look forward to it.
So, Daniel, we are at ASTMH, American Society for Tropical Medicine and Hygiene annual meeting, right?
Yes, yes. And I'm glad you got that all out because I'm just stuck with the acronym and then trying to remember.
Yeah, well, I think
because this is a 5-letter acronym. This is hard.
He throws in a few vowels here and there.
We should point out that a person who came to many of these meetings, Dixon Despommier, is here in Seattle. However, he's not here at the table.
He is not here at the table, and we'll be discussing a little bit of him almost as a case study. Well, no, as a case study for This Week in Virology when we talk about COVID later today. Unfortunately, Dixon cannot be with us because he tested positive. He's sheltering in his room at the moment. He's going to be starting on Paxlovid actually later today because we decided that we want to jump in. We want to reduce his chance of progression. We don't want to wait and see until it's too late because we care about Dixon and we want him to be here for many years to come.
That's great. You don't want to wait. Let's see what happens, and then we'll think about giving him Paxlovid, right?
Yes. Well, not if you actually care about the person. Now, if it's, okay.
So I'm really sad that we can't have Dixon here because this is his meeting. He's been to so many. And you said he was sitting in the booth yesterday and people were just coming up to him one after another, right?
It was like holding court. It was just so wonderful. It was having lots of people coming to say hello and having his book signed, and it was fantastic. It was really, really good.
It's too bad.
Yeah, it's
so
too
Aisha,
sad.
did you know Dixon at all?
I met him briefly at the booth as well, but yes, he had a significant presence.
Yeah. No,
but Aisha was not inhaling.
I was not inhaling.
She did not inhale, just
no,
for the record.
No, I was not inhaling. It was very brief, and I was, it was good distance.
Yeah, it's too bad he can't be, but maybe the next meeting we can get him to that one, Daniel.
Yeah, I think so. I think next year we're going to be in Chicago for the American Society of Tropical Medicine and Hygiene meeting. And actually, once we introduce Aisha to the world, hopefully we're going to be talking a little bit about what an exciting and fantastic meeting this is, and just what a great warm crowd. You go to a lot of meetings and it's kind of intimidating. I almost feel like ASTMH, the mentors are on stage. They're the ones intimidated. They're the ones, are you doing as good a job as you should be doing? So I think it's a great meeting for really for everyone at all stages.
Mm.
Go ahead, Christine.
I can second that. I'm usually not very good at participating at meetings, but this one has been really fantastic, and there's been such a breadth of topics that are being covered. I've just been really enjoying it. So it's a fantastic meeting, and I hope I can come back every year.
I think that's what's important about this one is that it's had a hiatus in person for so long, and I think that's one of the things that really makes the meat of ASTMH is the networking and the people that you collaborate with, and the friendships and colleagues and the projects that come out of this meeting. So I think it is really great that we're here in person and in a beautiful city of Seattle, of course.
All right. And so, Vincent, did you want to get to know Aisha?
Yes, we do. We'd like to know all about you, starting from, I used to say this and nobody ever got it, but I'll try it on you, starting when you were haploid.
Oh my, that's TMI.
It's like where you were born, right?
That's quite a long time ago.
Yeah.
Well, many, many years ago, I was born in a hospital called Misericordia in Edmonton, Alberta, Canada. So I was born and raised there in a family of 6 kids, of a first-generation immigrant family from Pakistan and India. And I have to say, it was a beautiful place to grow up. I did my med school training there. And then I moved to Toronto to do family medicine residency. And then I went to McGill in Montreal to do my emergency medicine residency. So I'm double boarded. And then I traveled all the way across the world to New Zealand, where I lived for 5 years. And that's actually where I ended up doing a postgraduate in travel medicine. But what's interesting about that is in New Zealand, most of the cases that we saw was tropical medicine. So that's kind of what piqued my interest in the tropical medicine world.
And do you know Daniel Griffin?
Do I ever? So I had the pleasure of first meeting Daniel Griffin in Thailand back in 2016 when I was doing an Asian clinical tropical medicine course. And that was fantastic. We were in Bangkok and we went out to Ratchaburi on the border of Myanmar where they have a malaria research station. We saw lots of cases of dengue, lots of great foodborne parasitic diseases, including nathostoma. And then we kind of fell off the radar, right?
Yeah, I'm trying to figure out, were you in Cambodia when I ran the marathon with the Thai princess?
Right. We were in Cambodia. So these guys decided, there was a marathon happening at Angkor Wat at 5 in the morning. And I was like, I will go in one of the tuk-tuks and make sure that you guys survive the marathon. But it just so happened that the princess of Thailand was running the marathon. And she had this huge entourage. And of course, you've got all these people doing the tropical medicine course trying to get selfies in with the princess running behind them. But that was it. That was the one.
Yeah. And then we meet again.
And then January 2022.
Yeah, this year.
Yeah, I was standing in the lobby of a hotel in Accra, Ghana, and waiting for a group to meet. So I was teaching on the TROP-Medics course that happens in Ghana, as well as in Tanzania and Uganda. And Daniel walks up in his mask and he says, "Hello, I'm Daniel." And I said, "Hello, I'm Aisha." And we had our masks on in the lobby. And I kind of looked at him and I said, "I know you from somewhere." And he's like, "Yeah, you look familiar." And he's like, "Take your mask off." And at that moment, it was like, oh my goodness. So it's been, it had been six years since we'd seen each other. And so then we had more adventures in Ghana on the TROP-Medics course there.
Yeah. So I always like this because I feel like Vincent is at heart an infectious disease doctor because this is like an infectious disease history. We go through this, where were you born? And then we even go into, and what did you eat? And were you swimming in fresh water during those years?
I was going to ask about the freshwater crab dish that you so enjoy, Daniel, when you're visiting Thailand. So did you share some together? Was there any consequences?
I had no consequences, but there was a lot of adventurous eating and adventurous activities. And the great thing about a group that's really interested in infections was, at one point we were plowing the rice paddies, with the oxen barefoot, water up to your knees.
Trying not to get melioidosis.
And then afterwards going through, what could we have gotten? The only difference is we were excited about what we could have gotten.
We were very excited to go home and get serologies done.
I get the impression that Daniel is pretty lax about, you say you swim in Lake Malawi, no problem, right?
But we toweled off briskly.
Yeah.
But I would have to say I was very impressed with Daniel's personal protective measures while we were in Ghana. Like in, wherever there was mosquitoes in sight, Daniel had his full sleeves, full, socks on, full pants. Like he was very much like, I'm not getting bit by a mosquito here.
Well, I know when I was in southern India, my garb was nicknamed Lame Disease, like sort of a tribute to Lyme, because I would tuck my pants into my socks. And
So I should give us a sense for what you do on a day-to-day basis. So you're professor of family and community medicine. You're also clinical director of travel medicine. So these involve clinical duties. What are those?
Yeah, so I feel like I'm a bit of a gypsy in medicine. So after I got interested in travel and tropical medicine, I came back and ended up doing the Gorgas course in Peru. And I had come back to Canada, and I really was interested in doing more travel and tropical medicine. But I find, in some countries, the specialty is very much siloed to infectious diseases or medical microbiology or whatnot. And coming from a background in family and emergency medicine, I thought there was a really great opportunity to kind of interface the primary care level with the specialty. So I ended up doing an infectious disease fellowship in Toronto at the Tropical Disease Unit in clinical tropical medicine. So now my clinical duties, they are a mix. So I still do urgent care. I see a lot of pre-travel and post-travel consultations at my travel clinic. And interestingly, through the urgent care and primary care and emergencies, I still do get referred a lot of post-travel or consultations in regards to returning fever, for example. I also work at Immigrant Women's Health Center. So mostly a sexual health clinic, but we do see a lot of marginalized, vulnerable populations, non-insured, illegals. And so we see all sorts of infectious diseases there that may or may not have been picked up previously, or that, kind of trigger us to kind of prompt more facilitation into navigating a lot of those migrant health access care points. And then, of course, I just happened to have finished my ID fellowship right before the pandemic, so I really was detoured to a lot of COVID work. What was interesting was with my crossover of COVID and travel medicine and ID and emergency, I ended up working everything from, being deployed to the ICU, to the emergency, to doing research on air travel and the safety of air travel. As well as I'm very proud, and Dan was very excited about this, but I was a PI on a research project looking at training dogs to sniff COVID. Which is they are incredibly sensitive, probably more sensitive than a PCR test at picking up COVID. And it was quite successful. We were able to garner over 4,000 samples from the COVID assessment centers across Toronto. And we trained up these dogs on the scents. And, we looked at the collaborating scent potentials and looked at the CT values of the positives and negatives. And with the goal of using these sniffer dogs to, potential, instead of PCR testing or testing at airports, using these sniffer dogs as, kind of picking up sentinels, just like drug testing or whatnot, and then you test as needed. What's interesting is these dogs can smell about 250 samples in 15 minutes, and they're very efficient at it. So that's a little bit of a nutshell of what I've been doing.
I want to ask more about the dogs. What kind of dogs are these?
So we had 2 chocolate labs and German Shepherd. So initially we actually were trying to get canine dogs and cancer dogs from Nova Scotia, and we had a little bit of trouble, negotiating these contracts, especially with the canine dogs. So what we realized that any dog can be trained up to do these COVID sniffing. And it's actually there's an interesting podcast by Malcolm Gladwell.
Who we should say is a fan of ours.
Yeah, the revolutionist
and we're
theory.
A fan of Malcolm's too. So.
Yeah, so he talks about the sniffer dogs and using that. But so the dogs that we got were bed bug smelling dogs from Montreal.
Wow.
So they're trained up to smell bed bugs, and we were able to train them up, and I'll show you the videos after. It's fantastic to watch them.
How do you train them? What do you do exactly?
So what we did at the COVID Assessment Center was we collected sweat samples from people coming in, and then we were able to validate which ones were positive and negative. So we initially, the way you have it is you have these little slots where the sweat sample is kept in these containers, and there's little holes, and basically you have A, B, C, D, and the dogs are brought in, and then they're taken to each of the samples, and then there's usually if it's a positive, there's some sort of reaction that they do. Usually they'll sit or they'll bark. And so, yeah, but it was a process because you initially have to get them, used to the sense of the neutral, and then to be able to differentiate, are they able to differentiate the positives and the negatives? So there's various steps to this for sure.
And then, so each dog, you give them a sample, and it's got to be in a situation where they're not smelling anything else to distract them, right?
Yeah, so we used an abandoned school in Toronto where we kept the dogs and the dog trainer. So they were pretty much, these were the scents. And yeah, so the way we do that is we kept the scents kind of closed in these plastic containers, and only kind of opened them up at those points.
So these, I guess, are axial samples, right? Sweat?
Yeah, so we took axial samples from, so the armpits and around the neck. And we collected a lot of data with these sweat samples as well. So we looked at, ethnic background. We looked like if we asked if they had eaten spicy food in the last 24 hours, if they were smokers and what kind of smokers. All these types of things could potentially have an impact on the scents that they were smelling.
And so these samples you had in parallel, a PCR test to know if it's positive, right? So
right, because they were already coming into the COVID Assessment Center. So it was great. So we had to go through each sample to see whether it's negative and positive. And we pulled out the CT values from the lab to see how positive they were. And what was interesting about some of these cases was that we also had a few that were negative because they may have had an exposure, and then they came back in a few days later, and they had turned positive. So it was really interesting to see whether the dogs could actually pick up the scent, preemptively before the PCR test went positive.
Sure.
And in 5 of the cases, that was the ability to do so. And it was nice because we were able to kind of collaborate to see what level of CT value they are able to pick up those cases at.
So what was the accuracy of the dogs? 99%, 100%?
I would say the puppy dog, the one who was like being freshly trained, he had only been doing bed bug sniffing for about 6 months. So he was a little bit less sensitive, so about, I would say 80 to 85%, but the German Shepherd and the other chocolate lab, they were sitting between 90-95% sensitivity.
Amazing.
Yeah, it was pretty incredible.
We should point out that they're not actually smelling the virus. They're smelling some volatiles probably that are made, right?
It's the volatile organic compounds that may be affiliated with the COVID scent. So yeah, it's that. So
is that interesting to find out exactly what volatiles are doing that? Is anyone looking at that? Do you know?
So on Malcolm Gladwell's podcast, they actually talk about just north of Birmingham, Alabama, there is a military center that actually does a lot of these scent testing for different things.
Yeah,
the puppy core. And then they're able to look at these compounds and then recreate synthetic compounds and distribute them around the world so that they can be used for these sniffing projects, whether it's for cancer or epilepsy or whatnot. So we specifically didn't look at the volatile organic compounds, but it's definitely something that would be interesting to see.
Yeah. I mean, also trace back what is inducing it. I mean, is it a cytokine or some other immune response or what? Would be really interesting to know that, right?
Yeah, absolutely.
So what is the purpose of these dogs? What would you use them for?
So, I mean, the study was in part funded by the Ministry of Transport. So the idea is to use them at places like airports, mass gatherings, and other kind of entry points for people coming, maybe traveling. Instead of using like mass PCR testing or rat testing, if you can use these dogs as people are coming in, and if they're able to pinpoint 1 or 2 people with positive volatile organic compounds for COVID, then those people would be pulled out for random select sampling of the test. So it's more efficient in overall.
Kind of like drug sniffing dogs, right?
Yeah, do you think it could work in that kind? Like, do you need to get the swab, the gauze, or could they just walk through a crowd and sniff out? Like I noticed yesterday, right? We're at the booth and one of those service dogs went by, and you noticed, I looked over, of course. I was just noticing the way it kept a wide girth around Dixon. That was what I noticed. But no, is this something where you could have it as an airport? They could be sitting there and as people walk by, they'd go over to the one, the way they do with like drugs.
Absolutely. So that would be kind of the last trial of the study, is to take them into these airports and different places to see whether they would, basically you would see which dogs responded, then we would test them to see if those tests actually came positive. Right now we just finished the phase where we had to blind both the dog trainer and the dogs, right? Because before the dog trainer could know which of the samples and maybe bias them. It does take a lot of time, right? These processes to train these dogs up.
And you can only train so much time per day because dogs, they get tired. So these short sessions, a few a day, and then,
Absolutely, yeah. And they smell better in the morning. So
don't we all?
We do. So I guess there wasn't a need for them in the end, right? We don't need that kind of screening any longer, so the dogs were not used ever?
So this was the largest validation study around the world. There were multiple studies done originally. The first ones done were in Lebanon. I know London School did a big one. The Netherlands did a big one. A lot of them were kind of at the level of 100 to 400. We were looking at 4,000. And one of the benefits that we had from our trial is that because of the way the REB, like the ethics board and just the process, we didn't actually start collecting a lot of our samples. So we have half our samples from Delta and Omicron. And so this is something that still definitely can be used in various settings. And I think may, depending on, which way the pandemic goes, we don't know. But even things like mass gatherings, for example, or
I wonder about other diseases, right? Like we'll mention Ebola a bit later. Like, are there ways, right? Because we don't have great ways of testing everyone. And particularly the idea that you can pick up pre-symptomatic, that people are already starting to smell differently. Does that improve the biosecurity at different entry points?
I can imagine a whole panel of dogs, each one with a different specialty, right?
You're walking past the line.
Right? I know.
Maybe you can get dogs with multiple specialties, since they seem to be able to transfer their knowledge from bed bugs
multidisciplinary
primary
puppy care clinic. Yeah.
And I think variants, right? Each different variant gives off a slightly different smell, so you may have to uptrain with the different variants. That's what we saw in some of the studies in the U.S.
Right.
So that's true. The variants, the dogs smell different.
So we particularly, that was one of the things that we made sure that we had the variants listed, and we checked to make sure, that the subtypes and whatnot were documented. So that's something that will come out in the data.
That's great. I'm glad to hear this. So Daniel and I used to talk about this, right? on the TWiP update, I think we mentioned that, and we often said we hope the dogs don't get COVID because it would be terrible if they lost their sense of smell.
Yeah, so that's why it's nicer to separate, and you've got them just smelling the gauze as opposed to being in that area. Because can you imagine if a dog lost its olfactory? So
the collaborators that I'm working with are vet behavioralists. And I also somehow got the project because my husband's a vet. But we actually did test all the dogs prior to starting the sampling, and they were tested kind of on a regular basis to see if there was any potential risk of infection from the exposure to the gauze. So luckily the dogs did not get COVID.
Great story. I like that. And you also mentioned, were you going to say something?
No. Anything that involves COVIDs and dog, I'm just, I'm on board. So.
You're on board with that. You mentioned also another study on airplane safety. Tell us about that.
Yeah, so during the early months of the pandemic, as a travel doctor, I was getting a lot of questions about air travel and how safe is it to go on an airplane. And I was like, I don't know. So I just happened to have various friends in the airline industry who are physicians. So I kind of got in contact with some of them, and some of them run the in-flight emergencies course for the emergency department in McGill. And I said, look, this is something something that we should look into? Is it, how safe is it to travel? And they kind of know the mechanics of it. So we ended up doing just like a review, looking at the potential risks of air travel during that time. And there were multiple reviews coming out at this time, because this was a point of question and concern for a lot of people. So we ended up doing two, actually, another scoping review as well, looking at kind of the impact of travel on COVID, but also just like the nitty-gritty of curb to curb or gate to gate transmission risks.
But you didn't do any studies on aircraft to see?
No, but there were some done by, like Boeing had a big one that was done, and they looked at kind of using like fluorescent particulate matter, where they had mannequins slowly breathing on the plane, this fluorescent matter, and then they were able to go and pick up to see where the droplets of this fluorescent kind of were spread to. So there were a few studies that were done. That was a big one that really brought to light kind of a lot of the risk. I think one of the big ones was the fact that it's the airflow in a plane is not longitudinal. It's like a laminar airflow, and so a lot of the planes are also have HEPA filters and HVAC filters. So that was one of the things where, with kind of a multidisciplinary, multi-pronged approach, including masking and whatnot, really decreased and mitigated a lot of the risk on flight. But I think what the issue was that it wasn't just the in-flight transmission, then it was more the gate-to-gate transmission, the risk at the airport, the risk going through security and whatnot as well, which potentially, and just being a vehicle to transport COVID, right? Was the other aspect of it.
But my understanding is that, as you say, the laminar flow is very effective at keeping viruses from going up and down the cabin. It's just, but that only happens after pushback, right? When they turn on those. Because if you're sitting at the gate, there's not much air circulation.
When the plane's on, right. And your highest risk is actually going to be when you're deboarding, when the plane's off.
That's right,
and the vents have gone off and everyone's jumped up and they've, they're massive follow. Well, at this point, people aren't masking. But yes, those are probably your highest risk points.
So I guess pre-vaccine, if you had to travel, a plane would be relatively safe with a mask, right?
Yeah, and I would have to say the planes were empty. I mean, I had the opportunity to travel during the pandemic, people weren't traveling. Like it was too restrictive with the PCR testing and whatnot. So, and that I almost felt like it was safer to travel during the pandemic.
We had that interesting experience with Ghana. Like when you arrive at the airport, you've prepaid, and everyone goes into a little booth and they do the deep. I mean, this was the deepest brain biopsy I ever experienced, and I was crying. Not with sadness, but and then you had to wait for the test to come back before you could even enter Ghana. And the same on the way out, you had to get a molecular test within 24 hours of getting back on a plane. So it was
even Uganda, I found they were very efficient. Every single person getting off the airplane was being tested intense, and you had those results back within 6 hours. It was quite impressive and very organized in a lot of these African countries.
But it made it a big challenge to travel. Like I've been starting to do more remote work again. I went to Panama, and then coming back from the archipelago, and then somehow trying to get a test in time to get back on the plane. I think a lot of the testing, impacted people traveling.
Yeah, and the cost barrier to it.
Yeah.
I was in South Africa last year just before the Omicron. I promise you I was not patient zero, although people question. And I had kind of popped over to Zimbabwe, Zambia, and I think the cost of just PCR testing was like something like $600 USD. It's very cost prohibitive.
So I suppose COVID had an impact on the kinds of travel-associated infections that you saw in Canada, right?
I mean, no one was traveling.
Yeah. Right.
It was interesting in the beginning, though, because in the very beginning at the COVID assessment centers, you had people who were traveling, and they were the ones earlier on, because PCR testing was really restricted as to who was being tested. And I remember, I had a resident with me at the assessment center, and he said, "Oh, this guy, he just came back from." He just come back from Uganda, and he has fever, and we tested him and we sent him home. And I was like, what? I was like, call them back and send them to the emergency because fever from Africa is still malaria until proven otherwise. But it really muddled kind of what people were thinking about potential differential. And I think that a lot was potentially missed early on. And now as well, with people restarting travel, we're trying to refresh a lot of the memories of emerge docs and primary care to think people are coming back. Fever, don't just think COVID. Like, think of potential things from various geographic regions that could be coming back now.
As Daniel says, there are other viruses out there. And you can have more than one infection.
You could have more than one thing at the same time.
Right.
And there's more out there than just COVID. No, that's a mentality I see all the time in New York, where they're like, they come in, a fever, I'm not feeling well, and like, well, it's not COVID, and they send them away.
Right.
Well, what is it?
Yeah, exactly.
And you could miss a malaria infection.
Yeah.
I suppose.
Sorry?
You could miss a malaria infection.
Oh, absolutely. Yeah. Absolutely. Right. And in the beginning, I think they were missing because they were just sending people home. You have fever, go isolate. So they weren't even being tested appropriately.
So now in your day-to-day experience, are things getting back to normal?
So there's a paper in the journal Travel Medicine written by Gerard Flaherty, who's the incoming president, and it talks about Reisangst, which is the fear of travel. And I think one of the things we're seeing right now is this anxiety around travel. So my travel clinic right now, the consults we're seeing have just exploded. And there's a lot of well-seasoned travelers coming in now who haven't been traveling for 2-3 years with a lot of anxiety around it. So I think there's more attention being paid to different things and different risks outside of travel. But I think also because people are just so not used to it anymore, they're coming back in. The other thing we're seeing with travel is multi-generational families coming in for large consults, like lifetime trips that people have been putting off, really high risk people traveling to multiple countries on many, many months. So the preparation is taking definitely longer, but I would see that's the really the significant thing is there is a lot of uncertainty and a lot of fear and anxiety around it.
I can say that this applied to me. I was incredibly, incredibly anxious to travel here, up to the point where I was on the plane, and then I kind of felt okay, but I was really, maybe for about a week beforehand, I was thinking, ooh, I'm a bit nervous. So I can understand.
Yeah, absolutely.
Yeah.
Mm-hmm.
Did you drink good scotch on the flight? Because that helps protect you against COVID and treats the anxiety.
I did have white wine.
I think the anxiety part is true.
We should have offered that one.
Probably not
I'm
enough
not sure
alcohol.
White wine is as effective.
No,
I'll have to look at the literature, though.
Not to mention the fact that you could deliver a baby on the plane at the same time. So
yeah, would you like to tell us a bit about that?
Yeah, you're sort of famous, actually, I believe.
Yeah, so little did I know that on my trip to Uganda in December that I would be delivering a baby on the plane.
How exciting!
Yeah, it was pretty crazy actually. So I was on my third leg of the journey to Uganda, and I was going from Toronto to London, Doha to Entebbe. I was exhausted. This is about a few weeks after Omicron had started kind of making its appearance. And I get on this plane. It was late from Heathrow to Doha. I get on the plane exhausted, like running through the airport. And an hour into the flight, they announced, is there a doctor on the plane? And I, said, yes, I'm a doctor. How can I help? And they said, well, we don't know what's happening. Something's happening back there. Go. And so I kind of go. It's dark. It's like 2 a.m. I'm exhausted. And I see this crowd of people overlooking the seat. And I'm thinking, oh, God, it's a heart attack. And I'm thinking, okay, where am I going to do my protected code blue? Like, I'm thinking, where am I going to do CPR? Like, there's a packed plane. And so I walk over and I say, hi, I'm Dr. Khatib. And the crowd splits. And there's a woman lying there on the seat with her head towards the aisle and her feet towards the window, and a baby was crowning.
Wow.
And I was like, this is not a heart attack. And somebody throws me gloves, because at that time they had like gloves and sanitizer. And there was like an air steward right in the kind of the row. And she's the only one who kind of looked like she was engaging the patient. And I looked at her and I said, do you know how to deliver a baby? And she's like, no. And I said, then move.
Move.
So essentially, I mean, I don't know anything about the story of this woman, anything. And this baby's coming out. So I literally like bend over and grab this baby to slow it down as it's coming out, thinking, I'm swearing in my head. Like, I'm just like, what? The last time I delivered a baby was over 10 years ago, in a very controlled hospital setting. And so this baby's coming out, and I'm trying to remember, like, okay, Apgars and like, okay, like stimulate the baby and whatnot. And I'm thinking, oh my God, what am I going to do here? And so, baby's out sitting on the seat. I'm literally bent over this woman who seemed to be very much in shock. And there's a lady who taps me on the shoulder. She's like, hi, I'm a nurse, but I'm an oncology nurse. And I said, I don't care what kind of nurse you are. Get me the medical kit. Look for something that says delivery kit. And I was just, talking out loud. I said, okay, if we don't have a delivery kit, I need clamps. I need scissors. If we don't have clamps, I need shoelaces. I said, I need hot water. And I said, no, I don't need hot water. But they always ask for hot water in the movie.
That's to keep the husband busy. Go boil some water.
Why do they ask for hot water? And I said, and all these scenes from like Bollywood movies and Hollywood are going through my head. I'm thinking, no, medical training. And then somebody else taps me on the other shoulder and she says, hi, I'm a pediatrician with MSF. And I said, great, we have a whole team. And luckily there was a delivery kit in the plane. And so we were able to clamp and cut the cord. And, the next part of it was delivering the placenta. And you can imagine I'm not a small person, so I'm like maneuvering my way. And I don't know a lot about this woman, and it's a precarious situation for her. She had been a migrant worker working in Saudi Arabia, and she had zero prenatal care. Didn't even know how far along she was. And she basically got on the plane and started having abdominal pain about an hour into the flight. The air steward noticed, and she's like, are you pregnant? And she said, that's when it dawned on her. She's like, oh my God, I think the baby's coming.
Wow.
But yeah, luckily everything went well and smoothly. And I remember I delivered the placenta. I was like, I need blankets, more airport blankets. It's going to be messy. And when I saw she was okay, baby was okay, and I said, okay, congratulations, it's a girl. And the entire plane burst out cheering and clapping. Like, I totally forgot there was this audience there. There was a 7-year-old girl watching over my shoulder. She watched the whole thing.
Wow.
But yeah, no, we got her moved up. We got her latched and breastfeeding right away. And so she, the sun came up over the Nile, and this little Ugandan baby was born. And then she named her after me. So she named her Miracle Aisha.
Nice.
Oh, lovely.
Yeah. That's a little miracle in the air. Yeah.
Tremendous.
Yeah. And then she got malaria 2 months ago. But that's the story.
So you're still staying in touch?
Yes, we have kept in touch. And, we started a GoFundMe to kind of help support her and whatnot. And since she's like, what should I do with the money? I said, well, the first thing you do is go get this kid vaccinated. And so now whenever she goes to get her vaccinated, she sends the vaccine record, she sends the pictures. It's very nice. But yeah, unfortunately, she did end up actually getting malaria and was admitted a couple months ago. And so that was the other thing is, go buy a mosquito net. And you don't think about these things, right? And the risk that these kids and whatnot are exposed to in these places.
Better than a heart attack, right?
Well, I was very lucky that things could have gone really wrong.
Yeah, it sounded like a straightforward delivery, right?
But we still had 5 hours left of the flight afterwards. So I was watching her like a hawk and, watching for postpartum hemorrhage. Like, I didn't know her anemia status. I didn't know her, her medical background and whatnot. So, and she had no prenatal care. So really, I was very lucky. She was very lucky that everything went smoothly.
Now,
and was that her first baby? Oh. Yeah, okay.
Now, so people like this woman, what's her a little bit about, people living in this situation? I guess she's from Doha, but working in Saudi Arabia.
She's from Uganda.
From Uganda,
yeah, so she's from Uganda. She's a migrant worker. Very commonly, we see a lot of migrant workers from Africa, from India, from Bangladesh, going to a lot of these. The Middle East, for example, is a very strong area for migrant workers. So she was working in Saudi Arabia, been in an abusive work situation, unfortunately.
Okay.
And like I said, that's why she had her zero prenatal care and whatnot, and she was about 35 weeks and was pretty much sent back to Uganda because she was going to be really unable to work at that point. So so that's why she had transited through Doha. She was going back to Entebbe. Yeah.
It's a great story.
Yeah.
Not quite TWiP story, but still great.
Sorry.
No, it's okay. I'll take it. I love it.
I think it's a very ASTM&H story. And
yeah, it
is.
is.
A lot of people here interested in people in these say vulnerable situations, migrant workers, a lot of refugees, a lot of displaced people.
Absolutely. And I guess to make it more of a TWiP story, there was a great talk at the ASTMH yesterday in one of the clinical meetings where Dr. Safa Barkati actually talked about screening for parasites in migrants and refugees, specifically talking about schistosomiasis, strongyloides, and other soil-transmitted helminths. And, there was a lot of discussion because there isn't really consistency for guidelines around the world. So it was actually really interesting for them to go through it and kind of the discussion of whether you just watch and wait versus you treat or test and treat, or whether you presumptively just treat. And I think cost effectively, they looked at it and said really the presumptive treatment is probably going to be your best bet in a lot of these situations for migrant workers and potential refugees and whatnot, depending on where they're coming from and where they're going to. A lot of the different countries also have different pre-migration requirements or recommendations for treatment, such as ivermectin, kind of, unless you're from a low endemic country. But then some countries will expect the testing to be done on site, or some will just give presumptive treatment. So there is a lot of variability.
So I think that ties quite nicely in with some other work that you've been involved in. I've seen you've as an author on a review paper that talks about treatment of soil-transmitted helminth in pregnant women. So I think that ties in quite nicely with your pregnant traveler on your plane to Uganda. So maybe we could talk a little bit about that. Did you mention that?
You're like, I just published on pregnancy. I feel really ready for this.
Well,
that peer-reviewed process.
I had actually just published on air travel and safety during the pandemic, so I felt like I was the...
You had it all covered. Air safety, pregnant women,
pregnancy.
I'm all good.
So that paper actually looked at, we had a lot of pregnant women coming into the tropical disease unit that had been referred with worms or, with stool that had been picked up or whatnot. They were having symptoms. And the reason we did the systematic review was really to look at safety of treatment in pregnancy. And a lot of times we see that pregnant women often aren't treated until after delivery because of the potential risk for some of the antiparasitics. And so the review actually looked at what are the detriment of leaving treatment. So, what are the things that these infectious parasites such as soil-transmitted helminths or strongyloides or schistosomiasis can cause in pregnancy, and one of the big ones was anemia and the impact of that on the fetus, whether it was intrauterine growth restriction or whether you had premature labor or other potential complications. And then they looked then at we then looked at who was treating with what and what trimester and potential safety issues that came along with it. So again, things like miscarriage or premature rupture of membranes, or were there other potential toxicity related to it. And the systematic review actually looked at there was actually not much difference in those who were being treated during pregnancy and those who were being treated after pregnancy in regards to potential adverse events. And so it's hard to really kind of correlate the causation of those events, but the actual difference between the ones who were treated during and after were different. The only one that actually showed the difference, and I wrote this a while ago, so I'm trying to remember, was I think it was treatment in the first trimester, and it was specifically to, I think, it was either metronidazole or albendazole, where there was a little bit slight caution. So the question is, do you wait to treat later in pregnancy versus earlier on? And often I think we do this for a lot of things anyways. We usually don't mess around too much in the first trimester, and then usually it's safer depending on it. Yeah, malaria is another one that would be really interesting to look at. We didn't look at that specifically, but yeah, for these ones, and I think the general consensus was there is benefit to treatment, specifically of the soil-transmitted helminths in pregnancy in regards to reduction of adverse event or adverse causes for pregnancy, especially things like anemia and intrauterine youth restriction. Yeah, there was a separate one on schistosomiasis and strongyloides. I think that was published afterwards.
Shall we swing you back to tell us about your work at ASTM&H?
Sure. Sounds great. So Daniel actually was just a invited speaker in the update course for the American Society of Tropical Medicine and Hygiene. So I am one of the co-chairs for the update course that we run every year. It is a fantastic 2-day course that we usually run on updates around clinical tropical medicine and travelers' health. And it's gone virtual, and we had a very successful course this year. We had 16 speakers live from all around the world, and I had to say we had 0 technical glitches, which is amazing. We even had actually we had one of the physicians who spoke about child malnutrition and nutrition from Tanzania at Solarian Hospital that I had met on one of these Trop Medics courses. And she was actually one of the first Maasai women to become a pediatrician against many odds. So that's one is the course, which I highly recommend people to look at. It's a great short update on things that are kind of coming up, but it's also a good way to review for those who are studying for the C-TROP exam, but also just, people working in the field who can't really maybe have the luxury of taking 2 to 8 weeks to go and do a tropical medicine course abroad. I'm also a counselor on the American Society of Tropical Medicine clinical group. And so with that, we've really tried to really engage more of the clinicians through ASTMH, and with the goal of kind of focusing on looking at the clinical aspects of tropical medicine. I know this the conference, is usually really research heavy and basic heavy, and usually we do like to focus on more of a clinical track for clinicians. This year we had a great talk at the Marco Longo from Dr. Mark Riddell on traveler's diarrhea. And kind of the advances around that, as well as kind of an update on the new Shigella vaccine, which was done by Dr. Kausar Talat. So, these are kind of the things that we're involved with. The clinical group also kind of helps promote clinical research and engaging trainees to be involved with that. So I was judging some fantastic presentations that were done from fellows and trainees around the world. On Sunday, for example, we had a great talk at looking at the parameters of a dengue vaccine, looking at, not vaccine, on dengue, looking at another one was looking again at a pregnancy and soil transmitted helminths, and kind of looking at PCR testing and molecular testing for that. So there's a lot of different ways to get involved, and we're always looking for input and feedback and engagement from people. There's also the pre-meeting course that's run through the clinical group. The update course was mostly focused on geographic diseases this year, with pre-meeting was more on syndromic kind of presentation. So I definitely encourage people to look at some of those options and get involved with the clinical group. Definitely reach out.
Yeah, I mean, I thought this was great. We had our booth, which you attended as well, and it was just great. All the people coming by, and a lot of them were like, here's our email. Let's get in touch. Let's get you involved in what we do, and let's stay connected. And it's been a great meeting. For basic science, for clinical. And it's also, I have to say, it's great just to see how many young people full of this energy, how many people were able to travel here from around the world. You just like each person you talk to is from Benin, from Togo, from a lot of other countries I will mispronounce. It's just a fantastic, and so you guys have done a great job.
Thank you, and we have to say appreciate Daniel's contributions as well with the parasitic diseases textbook, which we used. We actually had a clinical trivia night the other night, which was fantastic, and that was one of the prizes.
But if you got everything wrong, they gave you a textbook and said, study back next year.
Study this. It got quite controversial, some of these questions, for sure. Yeah. I think the most controversial one was the one that says, which is the most popular Halloween American chocolate?
Okay.
Yeah.
Okay.
Yeah.
What's the answer?
Would you pick Reese's Pieces cup, or like peanut butter cup, or would you say Snickers?
Reese's Cups.
Yeah, I'm a Snickers person down here.
No idea.
So the answer was Reese's peanut butter cup, but it was a red herring because they had Snickers on all the tables. So they would give me the book
and I have to study, because in the back we actually have that, information. Yeah,
really?
Yeah, no, it was great because there was a lot of people, experts from around the room. We had the Peruvians, we had people from the Asian clinical tropical medicine. We had, Pat Walker was there, and McCarthy was there. We had Lynn Chan, we had Herman Hernestroza. We had it was great, and then you had all these trainees and students, and everybody was really working together to get these answers. It was fantastic.
I think people are very happy to be back in person. I've been to a number of meetings this year, ASM, ID Week, and others, and people have missed being in person.
Absolutely.
Makes a big difference, right?
Absolutely. It really makes a big difference.
So,
yeah.
Anyway, Aisha Khatib from the University of Toronto has been our guest. Thank you for joining us today. Really enjoyed it.
Thank you so much for having me, and enjoy the rest of the conference.
Thank you.
Thank you so much.
Other part of TWiP, of course, is our clinical case. And Daniel, it's been a while, but remind us what we have here.
All right, I'm going to bring this up on the display, but while I'm doing that, I actually have it here on my laptop. Looks like everyone has a laptop.
There you go.
So, all right, we'll start off with our case from TWiP 209. So as I like to say, for those of you tuning in for the first time, or those of you tuning back in again, a man in his early 70s with a past medical history significant for hypertension, diabetes type 2, hyperlipidemia, BPH, benign prostatic hypertrophy, is admitted to the hospital after coming from Guatemala to visit his son. Oh, I have to move closer to the mic?
Yeah.
All right.
Because they're not hearing it.
Okay.
I can see you're frowning because you can't hear.
All right. should I repeat that? I'm going to repeat that. All right. All unedited. Early on I would make mistakes and then try to get Vincent to edit stuff out. He's like, I'm sorry.
Not true. I take it all out.
Okay. Man in his early 70s with a past medical history significant for hypertension, diabetes type 2, hyperlipidemia, benign prostatic hypertrophy, is admitted to the hospital after coming from Guatemala to visit his son. He actually comes from the capital, which is Guatemala City. Little trivia there. He feels faint. I don't do that unless it's like something I can pronounce. He feels faint with standing and is noted to have a heart rate in the 40s. He does not feel well when he stands. He's also noted to have diarrhea, but this has been going on for an unclear period of time. On the EKG, he is noticed to have a right bundle branch block. Doesn't report any prior surgeries. There's no known adverse drug reactions when we look for allergies. For Vincent's benefit, because he's very thorough, social history, no toxic habits are reported. He reports living in Guatemala City. He was born there in Guatemala, but he grew up in the rural areas before moving to the big city. He does enjoy drinking fruit juice. Family history, non-contributory. Now, on exam, he has a slow heart rate. He is orthostatic, so we stand him up. That heart rate doesn't change, but he becomes faint. Blood pressure does not adjust. A number of blood and stool tests are collected, and he is referred to a tertiary care center for implantation of a cardiac pacemaker. At the tertiary care center, the patient is seen by an infectious disease specialist, and a number of tests are ordered by that infectious disease consultant, but they are canceled by the cardiologist, who writes in his note, no concern for an infectious process. Now, one of the tests collected at the first hospital returns with an interesting result that is later confirmed by a second test.
Cardiologist, huh? Okay.
I think we joked last time that he now runs a research center. So.
All right, we have a lot of guesses for this one. Christina, can you take the first one?
Okay, so the Parasitology Club of Central Lancashire writes, greetings from Parasitology Club at the University of Central Lancashire in the beautiful northwest of England. Currently the weather has started to bring us autumn. It is 6C in the evening and 15C in the day. The UK weather is not so cold for this time of year. We would like to add our considered opinion for the elderly Guatemalan gentleman with multiple comorbidities who was admitted to the acronym City Hospital with right bundle branch blockage and diarrhea for an unspecified period. The most probable cause of the condition is flagellate protozoan parasite Trypanosoma cruzi, which causes Chagas disease. The infection is spread through vector-borne transmission when parasite trypanomastigotes are introduced through broken skin or mucous membranes from the excreta of triatomine insects in areas of endemicity. However, Fujita et al. In Brazil reported an association between Chagas disease and the consumption of contaminated acai fruit products. A minority of patients develop an acute syndrome for 4 to 8 weeks. These symptoms include prolonged fever, subcutaneous edema, myocarditis, and meningoencephalitis. The acute syndrome resolves even if it is not treated with antibiotics. In 30 to 40% of cases, cardiac or digestive disorders similar to those experienced by the case develop. Trypanosomiasis is endemic in South and Central America and parts of North America, and 8 million people are affected. In a study by Bocci et al. Of Latin Americans living in Los Angeles suffering from right bundle branch block and left anterior fascicular block, 17.9% had Chagas disease. During the acute phase, treatment is focused on managing symptoms and eliminating the parasite. Benzimidazole and nifurtimox are drugs of choice. The chronic phase cannot be cured by medication, but sudden cardiac death may be mitigated by heart transplant or implanted defibrillator, cardioverter devices. Thank you once again for a wonderful and challenging parasitology case. And that's Chaskirat on behalf of the Parasitology Club.
So, Christina, acai. Not acai.
I've never heard of that.
Yeah, it's acai, right? Okay, Daniel.
All right. Hello, folk. Greetings from a sunny day in Quebec in Canada. I am working in my archaeoparasitology lab with views to the St. Lawrence River listening to TWiP. I am going to go straight to my diagnosis. I believe the patient shows signs of Chagas disease caused by Trypanosoma cruzi. Although referred to as vector-borne disease, oral transmission of Chagas has increased in the past few years, and the consumption of juices made with fresh fruit is identified as one of the main causes of this increase. The pathogenesis described aligns with the chronic symptoms of the disease. Orthostatic stress and slow heart rate have been observed in patients, and arterial hypertension has also been correlated to Chagas. Diarrhea is common in the acute phase, and since the patient has noticed it for a longer period of time than the symptoms that took him to the doctor, it may indicate persistence and a quick evolution to a chronic phase, which has been noted in many orally transmitted cases. I found myself interpelled by this week's case as I am working with archaeological remains that also show signs of the same infection, looking at a disease with more than 9,000 years of infection to humans. Thank you for all you do, Ida. Consider me for the book, please. Okay.
That's quite astonishing. 9,000 years, yeah?
It's fantastic.
Yeah.
I don't know what interpelled means. I've
Me
never
neither.
heard that one. That's a new word. I looked it up. There's no definition.
Okay.
All right, Chelsea writes, I'm back from Bat Cave, North Carolina. On this beautiful, sunny, 48-degree morning, my guest for episode 210 is Chagas disease, based on the man's residence in Guatemala, where Chagas is endemic, as well as his EKG results and dizziness upon standing. Living in rural Guatemala in a thatched roof home is a risk factor for exposure to the triatomine bug vector. Chagas disease is spread primarily via the feces of triatamine bugs infected with the parasite T. cruzi. The parasite present in the feces of the infected bug then enters the host through the bite wound. Additionally, vertical transmission and infection via blood transfusion are possible, and less commonly, Chagas can be spread orally. The patient's mention of enjoying fruit juice sparked my curiosity here. High temperatures and the lack of moisture can kill the T. cruzi parasite, as well as freezing. Ideal conditions for T. cruzi survival and growth include ambient temperature and liquid or high moisture content. As such, according to an article by Michael Miles in the Journal of Infectious Diseases, palm, sugarcane, and fruit juices are therefore ideal contaminated sources for oral outbreaks because they're often grown, harvested, and pressed locally with the aid of artificial light in rural or peri-urban areas where sylvatic triatamines may be abundant. Specific to Guatemala, another study reported an outbreak of Chagas related to homemade guava juice. An outbreak was traced to in-home production of the juice, which included a period of time in which the juice was left out overnight, allowing triatamines and vegetation to fall into the juice, leading to contamination. Lastly, related to the EKG results, a slow heart rate and right bundle branch block are common in patients with chronic Chagas. Cardiovascular complications can also result in dizziness. That's my guess, and I'm sticking to it. Look forward to hearing your diagnosis. This reminds me of Nipah transmitted by date palm sap.
Yes, yeah.
Right? The bats pee in the date palm at night, and there goes the virus.
Oh, that's a thought.
Yeah.
That's a thought. Maybe TMI.
I think one of the thoughts I'll suggest is that when they're mixing thing up, particularly the sugar cane, which they're going to use to sweeten these, that the bugs may be in the sugar cane. Should this be Chagas, and that may be a route of transmission.
Because we don't know if it's Chagas yet.
We don't know yet. Yeah, we haven't done the unveil.
All right. Back to you, Christina.
Kimona writes, so thankful for your monthly therapeutic rants, and the case studies are truly parasitic. They won't leave my mind until I make an attempt at solving. I believe the old man is suffering from chronic Chagas disease caused by a Trypanosoma cruzi infection. He likely encountered an infected triatomine reduvid bug one night while sleeping in his thatched hut as a child in rural Guatemala. Or perhaps he drank some fresh fruit juice containing a squished bug or two. He may even recall having had a swollen eyelid, a Romagna sign, or a chagoma at some point in childhood. At this time, his infection is in a chronic, latent phase, and parasite persistent in tissues is the main mechanism of pathogenesis. In his heart, cell damage has caused myocardial fibrosis and disrupted the conduction system, causing the classic early finding of right bundle branch something seen on his EKG.
Right bundle branch block.
Ah, was the block. Couldn't remember the block. I imagine that the serum IgG test, ordered by an astute ID doctor and clearly not the cardiologist, was positive. 2 positive serology tests are needed to confirm the diagnosis. Treatment options for this gentleman are limited. Both nifurtimox and benznidazole are limited by toxicity and poor cure rates, especially in ages over 50. They are indicated for acute, congenital, or reactivated infection. I read a 2019 PLOS neglected tropical disease paper that discussed the use of prospective vaccines for both preventative and therapeutic purposes. Vaccines in mouse models have been shown to reduce parasite burden by redirecting the immune response. In this fashion, they might be capable of reducing both congenital transmission in pregnant seropositive women, as well as halting the progression of cardiac complications in chronic Chagas disease. Imagine that. But alas, science is not there yet, so I fear this gentleman's fate rests in the hands of a narrow-minded cardiologist. A pacemaker will surely be implanted for his bradycardia, and he has signs of dilated cardiomyopathy and heart failure. Other management, such as diuretics, may help prevent even further progression. Grateful, as always, Kimona. Do you want me to read the rest?
Sure, you could read that, yeah.
P.S. Vincent, I guess I shouldn't be surprised that you'd recognise my name, Kimona, which was brought back by my grandparents who spent 40 plus years in the DRC. My grandfather remains buried over there, having succumbed in the late 1960s to the bite of a tsetse fly and African trypanosomiasis. I don't believe we had treatments back then.
Yeah, Kimona was a PhD student in my department many years ago.
Oh, I remember.
I recognized her name. It's a very unique name.
Yes.
It is.
Yeah. I think we talked about that in the last
we
week.
did.
Yeah.
Daniel.
Alice writes, greetings from Washington, D.C., where ID Week is about to begin and the U.S. Capitol will be overtaken by infectious disease curiosos. In regards to the gentleman from Guatemala, I suspect he has chronic trypanosomiasis from T. cruzi infection leading to heart block. His endemic origin gives concern for this. If this gentleman would have been from the Midwest and enjoyed outdoor tick-heavy activities, I might also suggest Lyme borreliosis. However, this is a parasite podcast. In chronic trypanosomiasis, the diagnosis is confirmed when 2 serological testing based on different antigens should be used in parallel to confirm accuracy of diagnosis. Thank you for this excellent podcast and all the Microbe TV content. Alice Lehman. And Alice Lehman is CTROP. She has a certificate in tropical medicine, and she's a PGY6 infectious disease fellow at University of Minnesota.
She might even be at this meeting.
I think she might. Hopefully she is. If she is, she should stop by.
Gina writes, my best guess is Chagas disease caused by the parasite T. cruzi. The insect vector is informally called the kissing bug, which often lives in thatched roofs in the Americas. It's known to cause heart problems if not treated early. It also has a history of transmission through blood transfusions. I look forward to hearing the right answer. Tell Dixon I liked his sign-off, and all of your podcasts worm their way into our waiting memories. I also listen to his urban agriculture podcast, even though my memory is waning, or is the proper term contracting?
Oh, I love that. I love that.
It is. My
TWiP listener, yes.
There's no more waning, no more. It's contracting. I love it. That's great. Christina.
Oh, I've got another long one from the first Vienna Parasitology Passion Club. Dear Reduvi Dudes, a Guatemalan gentleman visiting the US presence with orthostatic symptoms, bradycardia, and conduction abnormality. When considering the combination of right bundle branch block and hemodynamically relevant bradyarrhythmia, we can divide our differential in 2 important categories: non-structural causes like electrolyte abnormalities, intoxications, etc., and the structural causes. The most common etiology to consider would be ischemic heart disease and resulting cardiomyopathy. Other important causes are toxic cardiomyopathy through alcohol, genetic causes, valvular pathology, infiltrative disease, and myocarditis. The history of this patient is suggestive of 2 of these etiologies. His age and comorbidity put him at an increased risk for ischemic heart disease, while his country of origin, residing in rural areas and possibly the partiality to fresh fruit juices, point towards Chagas disease as a cause for cardiomyopathy with conduction delays. We recommend a repeat EKG, an echocardiogram, lab examinations with lipid profile, HbA1c, and possibly HS troponin to rule out myocarditis or an acute ischemic event. Furthermore, a serology for Chagas disease with both ELISA and IFA is strongly recommended. Imaging and/or endoscopy may follow in order to evaluate for other manifestations of the disease, including colonic disease as a possible explanation for the diarrhea, and esophageal dilation and achalasia. Microscopic evaluation of the diseased tissue is not very sensitive and should not be routinely performed. Therapy options for Chagas depend on whether the diagnosis is made during the acute or the chronic stage of the disease. During the acute illness, medications such as benznidazole and nifurtimox can be used. These drugs may also be beneficial for congenital infection in infants and in immune-suppressed individuals. For chronic Chagas disease, there is currently no curative medication available, but benznidazole and nifurtimox may reduce disease progression. Another important factor when treating chronic Chagas disease is the management of Chagas-related heart conditions and gastrointestinal symptoms. Thank you all for this great case. All the best. And that's Michelle and Alexander on behalf of the First Vienna Parasitology Passion Club.
Daniel.
Ramu writes, hello from beautiful Providence where fall is in full swing. I've been meaning to write for a while now and happy to do it now. I've been listening to this podcast during my TWiP Med Diploma course and have recommended it to my other colleagues as well. This was a fantastic adjunct to the course, especially the first episodes of the show. Those were Dixon's. I think you, Dixon and Vincent, that it was a duo. Yeah, so a great
25 or so episodes.
Yeah, great intro, sort of going through each eukaryotic parasite. This was a fantastic adjunct to the course, especially the first episodes of the show. I am now preparing for the CTROP Med exam, which is coming up in a few weeks. Good luck. This man from Guatemala likely has cardiomyopathy from chronic Chagas disease caused by American trypanosome. Though primarily transmitted by triatamine insects, this patient could have gotten it orally since he loves fruit juice so much. This is a disease with a large public health impact and is now found outside of South America as well. Thank you for the knowledge you are disseminating. Fan of the show, Ramu.
Raquel and Leon write, we are two ongoing scientists from Buenos Aires, Argentina, and Grenoble, France, who met each other 1 week ago in Brazil at a trypanosome at TID's summer school, and now decided to solve TWiP cases together. Lovely. I wonder if romance is involved. Cardiac romance and the parasite. What a good combination. The cardiac.
Well, I was just wondering if this turns out to be Chagas with the kissing bug, then maybe it's apropos.
The cardiac involvement and the difficulty of detection, together with the conditions the patient grew up in, let our bells ring. For us, it sounded like chronic Chagas. EKG results showing RBBB is one of the hallmarks of chronic Chagas. The unspecified chronic diarrhea could also be a sign of intestinal involvement. Therefore, they should run some more tests to confirm it, though it could not be related at all. Diagnosis fits perfectly with the geographic and social situations where the patient grew up. Since T. cruzi is endemic in Guatemala, you can get infected with T. cruzi through the consumption of food, fruit juice, contaminated with feces of kissing bugs. Because of the patient's pre-medical history and the nature of chronic Chagas, it's not surprising that the cardiologist could not find any evidence for an infection process. The blood taken at the first medical facility could have been tested for IgG, which is the standard diagnosis for Chagas, and this test had to be confirmed with a second IgG because one is not reliable enough. PCR is not routinely performed, but it could be worth it. The alternative would be heart tissue biopsy. Might not be advisable for an old patient, especially with his previous medical history. Treatment must be individualized based on risk benefits. Best greetings from two passionate trypanosome scientists, Raquel and Leon. Great. Christina.
Jason writes, and actually Jason could have just come and read out his own letter because he's based in Seattle. Dear TWiP Post, it is a cool 13 degrees C here in Seattle, Washington. I'm a long-time fan of TWiP and felt the time was long overdue to try my hand at the case diagnosis and the shot at the parasitic diseases text. In the case of the Heartsick Guatemalan Septuagenarian, the patient presents with an aberrant ECG exhibiting both a right bundle branch block and the junctional heart rhythm with a rate in the 40s range. Both the bundle branch block and the apparent absence of a functioning sinoatrial node is suggestive of at least two structural defects within the heart. These ECG findings, coupled with the history of rural living in Central America in decades past, raises the diagnosis of chronic infection with Trypanosoma cruzi to the fore of the differential diagnosis. T. cruzi is the protozoan parasite responsible for the disease known as American trypanosomiasis, also known as Chagas disease. T. cruzi is a vector-borne disease transmitted by nocturnal blood-feeding triatomine bugs, but sometimes is acquired via organ transplant centrally, or via contaminated food and drink. Until a diagnosis of Chagas cardiomyopathy, cardiomyopathy can be confirmed via serologic testing for IgG antibodies to T. cruzi, prudent diagnosticians should consider other etiologies as well. According to the 9th editions of the Hunter's Tropical Medicine text, these include ischemic heart disease, cytomegalovirus, HIV, post-streptococcal rheumatic fever, Lyme disease, histoplasmosis, systemic lupus systemic lupus, and sarcoidosis, to name a few. I'm a former Army Special Forces medic with years of service in low and middle-income countries, and I'm now a full-time medical educator specializing in trauma care, tropical medicine, advanced cardiac life support, and minor surgical procedures. I have just begun my final year at the London School of Hygiene and Tropical Medicine Masters in Infectious Diseases program. Warm regards, Jason.
I like that, warm regards.
I know. Good luck with the MSc, Jason.
Daniel.
All right, Mark writes, hi, TWiPers. I think the patient has Chagas disease, American trypanosomiasis, caused by the parasite Trypanosoma cruzi. I looked up parasites that affect the heart and found a page listing 5. Oh, I like this, a nice differential. Of those, 3 were described as causing heart arrhythmia: Trichinella spiralis, Echinococcus granulosus, and Trypanosoma cruzi. I looked them up on Wikipedia, thinking he needs a book. Of those, T. cruzi seem to be the most likely because it is common in Central America in rural areas, which is where the patient grew up, and because one route of acquisition is drinking contaminated fruit juice. And Dr. Griffin specifically mentioned that the patient enjoys drinking fruit juice. Who doesn't? The fact that the patient no longer lives in a rural area is consistent because heart disease is a long-term manifestation of Chagas disease. Cheers, Mark.
Kate writes, hello all. Happy Sunday from a rainy Washington, D.C. I believe this week's case is a man with Chagas, typically transmitted through the feces of the triadenine vector. These patients' EKG findings are classic for Chagas cardiomyopathy. It is sad and frustrating to hear the cardiologist's dismissal of a potential infectious cause. I hope that the patient's family and son are screened for T. cruzi, ELISA, and IFA to potentially receive treatment prior to symptom onset. Treatment would include either nifurtimox or benznidazole, depending on age of the patient. Christina.
Kevin writes, Dear Doctors TWiP, when I first listened to the TWiP episode, I drew a blank on parasites that cause heart complications in humans. But then later that week, I was listening to TWiP, and when Dr. Despommier mentioned myocarditis caused by Chagas disease, it clicked. Suddenly, the thatched roof home fit into place as well. Thus, I submit Trypanosoma cruzi as my case guest. I hope the family can acquire bed nets to protect the patient's wife and children from the present kissing box. Keep on cruising. Kevin.
Daniel.
All right, I'm going to take a few here because they're short ones. Martha writes, greetings, TWiPers. I'm on the road without the red book. So Googled, parasite, heart block, Guatemala. My answer is Chagas disease caused by Trypanosoma cruzi, named after Dr. Carlos Chagas and Dr. Oswald Cruz, respectively. The good old days when people were honored to have diseases and disease-causing organisms named after them.
They don't any longer want them named after them. Well, certainly not places, right?
Well, if there's a Griffin disease, I'm happy to, bear that. All right. Annette writes, hello, TWiPers. I think that's because it's right around Halloween. So greetings from a cold and rainy Braunschweig, 10 degrees C. My guess is Trypanosoma cruzi, which causes Chagas disease. In its chronic state, the symptoms correspond with those described. Looking forward to listen to all those well-written letters each month. Thanks for all the TWiBs, Annette.
Daniel, there will never be a Racaniello disease. It's too long. Right?
And my name is unpronounceable, so...
All right, I'll do this last one here, and then we'll
pronounce it.
So
Go ahead.
Ben writes, Dear TWiPers, in Washington, D.C., it is negative 7.765 degree W. Parasite, Trypanosoma cruzi. Thank you, Ben. Ineligible as a prior winner. Does anyone still use gentian violet to treat transfusion blood?
I have no idea.
No.
All right.
Okay, this one, I'm really glad I get this one. This is from Cindy. Listeners of TWiP will remember. Cindy writes, "Hey crew, I'm that small town New England cop who wrote to you with some questions at the beginning of the pandemic. So Cindy wanted to know about PPE for a cop. She said, all I got are gloves and a Glock." Isn't that cool?
I like that.
And I've been wondering where she's been, and now
here
she
she is.
reports on TWiP. I love it. Okay, we fared well with not much interesting to report. The constant information you provide us helped a lot of us stay safe. I'm glad, Cindy. For the case study, I'll pile in with, I'm sure, a bunch of folks and say our gentleman likely has Chagas cardiomyopathy caused by the protozoan T. cruzi. Probably drank squished triatamines or triatamine poop. Ew. Cindy, you got away with words. I love it. As for treatment, I would radio dispatch to send rescue and let the EMTs get him to the proper doctors. I'll worry about the bad guys. Thanks for enriching us science nerds wherever we are. Oh my God, I love this. This is just so great.
It's fun, yeah.
Christina.
Christopher writes, "Hello. I think I'm gonna skip.
He TWiP Terrace.
TWiP Terrace. I don't get that. That's my jet lag. I blame my jet lag. Writing this case guest for episode 209 from David Geffen School of Medicine, where I am preparing for my first clinical rotation. I cannot wait to diagnose all the parasitic infections. For the case of the 70-year-old male who visited Guatemala, my guess is Trypanosoma cruzi, the etiologic agent of Chagas disease. This parasite is a significant cause of cardiomyopathy and can lead to the EKG findings described. This parasite is usually transmitted by the bite of a hemipteran kissing bug. However, one of the many mind-blowing facts I learned from Professor Eva Harris' molecular parasitology class at UC Berkeley was that drinking blended bugs has become quite a problem. To get a healthy dose of antioxidants and vitamin, one might want to enjoy a nice, what was it again? Acai? My apologies. Berry or guava smoothie. The problem is a kissing bug might be hitching a ride on the fruit, and if it is blended, one might also be getting an unhealthy dose of bug guts and trypanosomes along with it. Should I be concerned about the prepackaged acai smoothies they sell at the store, or does freezing kill the trypanosomes? Was that okay?
It's good.
Thank you for all you do. Have not won a book yet.
All right. And our last one, Daniel.
All right. Sarah writes, "Dear Doctors Racaniello," did I get that right? Dixon, Despommier, Daniel Griffin, and Christine Nola. Instead of the weather, I will describe... Did I pronounce it wrong? Naula. Okay, good golly. Okay. Instead of the weather, I will describe the tea I am sipping. It brought joyful tears to my eyes the first time I tasted it. It is an oolong tea from Taiwan called Dongfang Meiren. The first sip I had of this tea, courtesy of my co-intern, surprised me with the sweet aroma of Moscato wine, followed by the scent of peonies and ripe golden figs. At the end of a sip, the tea glimmers like sunlight hitting honeycomb. I assumed the tea leaves were flavored with something, dried grapes maybe, or peony petals. But no, I was wrong. The tea leaves somehow expressed all these flavors on their own. I had to find out how. The answer, the tiny tea jacide, Jacobiasca formosana, the critter bites into a tea leaf, triggering a chemical reaction whereby a terpene and an aromatic compound called hot trianol are released. These compounds in turn attract a spider who comes to eat the tea jacid, unless the jacid jumps away. The result of this fascinating relationship is that when the tea leaves are picked and oxidized, the flavors released could bring a person, or at least this person, to tears. It can be steeped at negative or at about 195 F or about 95 C for 1 to 2 minutes. All right.
Sounds good.
Yeah.
I want to be brought to tears by
so
tea.
we'll be pausing right now and getting tea.
Yeah, I'll look for some.
Okay. All right, now on to the case. This is Trypanosoma cruzi, the cause of Chagas disease, transmitted by the kissing bug that burrows into mud huts. The protozoan appears like a scarf waving in the wind under H&E stain. It is introduced when the kissing bug defecates in its own bite, less common, or defecates near the bite or mucous membrane, and the person rubs the bite feces into an open wound or the eye or the mouth. Unfortunately for this individual, I believe his isolated arrhythmia is from chronic trypanosomiasis, and the main treatments to offer him at this stage are a permanent pacemaker and routine treatment for any heart failure he has developed. He could qualify for a heart transplant. However, I think reinfections are also possible, so it might be important to provide some kind of prophylaxis or suppressive therapy. Given the high rates of vertical transmission, if the patient were a person capable of bearing children, it would be especially important to eradicate any parasites present prior to pregnancy. The treatment is benzimidazole and providing people with bug-free housing. The unfortunate hubris of the cardiologist involved in the case recalls something my grandmother used to tell me when she was still living. Don't distract yourself with what you already know. It's what you have to learn that should concern you. To me, each of you 4 professors exemplify this maxim, and it's absolutely inspiring as a young trainee to see people as experienced as you are continuing to approach science with humility and wonder. I hope I will always be able to follow your example. Thank you so much for teaching me, Sarah. And P.S., I still haven't won a book, but I'm keeping my hopes up. I should channel Dixon here, right? Because I know what he would say at this point. You know, one of the first transplants ever done in the world was in a patient that had Chagas disease and a dilated cardiomyopathy. Okay. That was Dixon.
The South African patient?
I think it was Brazilian, actually.
It was Brazilian?
Yeah, it was a Brazilian patient.
Wow. Well, I really like this. To me, each of you exemplify this maxim and are inspiring. That's what we're trying to do, right?
Yeah,
we want to inspire.
I just feel quite honoured reading that about myself and us. So,
well, I hope we get across the humility. I mean, I have so much to learn. You know, when I see a patient, and we'll talk about the patient, our new case, when I initially saw them, it didn't jump to my mind. I went back, and then I looked the second time, and I said, oh, yes. So, no, I think that's really important.
All right. So Dixon, I'm saying, he's not even here.
It's because I channeled so well.
That's right, you did. What do we have here, Daniel?
Well, I think we still have 2 more people to guess, and then we get to wrap it up. So,
okay, I'm going to keep it short. I think this is Chagas disease, chronic Chagas disease caused by Trypanosoma cruzi. Okay. So I'm in agreement with all our listeners.
Okay.
Oh, it's right bundle block, EKG, cardiomyopathy. Classic Chagas, clearly.
Yeah. So that was, initially when I was the person who saw this at the original outside hospital, right? That's become a thing we often refer to before they went to the tertiary. So I was that physician that ordered that first test. A partner of mine saw them at the second facility where their tests were canceled. So the first test came back positive, serology. We confirmed it with a second test, so felt very comfortable with this being Chagas. I mean, as our emailers wrote in, there's a lot of great history here as a gentleman from the right place, the right risk factors, the right clinical presentation. As far as why do we care? How does this impact management? And some people actually wrote in about this. A gentleman who has a dilated cardiomyopathy, heart failure from Chagas, might not just need a pacer, they may actually need a implantable defibrillator, so an AICD. So it may actually affect management right then before they jump in with this device.
So you hand this patient off to others to take care of him, basically, right?
Well, so I'm at this outside hospital, which is funny. I rotate. Sometimes I'm at the tertiary center. Sometimes I'm at the outside hospital. Yeah. So I sort of I think the perspective is great. My first job was a rural hospital in Montana. I was like the only doc on the weekends. And then I would refer them. And funny, I would be sometimes calling the tertiary hospital where my main job was. And, they give me a hard time, like, I'm going to see you Monday. So then I go to the tertiary. So in this case, my partner took care of him at the tertiary hospital. We communicated. We took care of him after discharge. And then this gentleman ended up back in Guatemala City.
Nice. All right, we're going to give away a book. I've picked a random number between 1 and 15. We had 15 guesses, and the number is 4. So that makes Gina the winner, who guessed correctly. Everybody guessed correctly, right?
Yes.
So Gina, send your address. I actually know your address because you sent me a card once. But Gina, send your address to TWiP@microbe.tv, and we'll get you a book. Now we have another case, perhaps, Daniel?
We do. We have another case, and I've actually started putting these into the show notes for everyone's benefit. So this is a recent case. I say we are consulted. I am consulted. I get the call, and I go to see a man in his mid-60s. I do the Vincent Racaniello history. Where were you born? And he was born and grew up his early years in Hong Kong. This is why infectious disease consultations take so long, because we chat. And so we chat for a long time about all the changes. So he is born and he grows up in Hong Kong, but now he's living in the United States for many years. He has a past medical history significant for diabetes type 2, hypertension, benign prostatic hypertrophy, chronic hepatitis B, COPD. He's not on home oxygen. He's a current smoker, which he shouldn't be doing, end-stage renal disease, on dialysis with a right chest catheter for dialysis access, and he gets his dialysis Monday, Wednesday, Friday. He presents to the emergency department with progressive shortness of breath, dyspnea on exertion for about a week. When I go through, I learned that 2 weeks prior, the patient missed one session of hemodialysis. Later, I'm going to talk to his kidney doctor a bit about his compliance. The progressive worsening, shortness of breath, dyspnea on exertion, and orthopnea, right? So he tries to lay down, so the position makes the breathing worse. It began to develop about a week ago. There's a productive cough with white sputum. His last dialysis session was 3 days prior to admission. He also began developing nausea and vomiting for 3 days, about 12 times last week. There was the vomiting, so a lot of vomiting going on. Also started developing some loose stools, diarrhea. Patient also has, and this is why they call me, a generalized, really itchy rash for about 3 months that has been worsening. He reports that he's been seen by a dermatologist and told that the rash is due to certain allergies from foods, which he will not stop eating. And he's been using an unknown cream for 1 month that does not seem to be helpful. Of note, he was recently admitted for the management of bleeding from the permacath. Acute hypoxic respiratory failure felt to be secondary to his COPD that actually required intubation and ventilatory support. He denies any recent travel, recent antibiotic use, or sick contacts. But his nephrologist reaches out and is concerned about a certain diagnosis. As he says, 3 other patients that come for dialysis have recently been diagnosed with a certain diagnosis. So on exam, he has this diffuse, and I mean diffuse, his entire body is covered with this symmetrical raised rash. You're almost looking for areas that are not affected. He's scratching the entire time. I ask him, is it worse during the day? Is it worse at night? It's worse all the time, Dr. Griffin. On careful examination, and I will say, to be completely full disclosure, I go back and carefully examine him a second time after speaking to his nephrologist. I see these linear scabbed areas between his fingers. We get some lab work on him. His little bit anemic. His white count is in the normal range, but his absolute eosinophil count is greater than 1,000. So absolute eosinophil count greater than 1,000. His BUN is 51, creatinine 5.1. And so I will leave that as our mystery case. Any questions?
So this man has a family? Is the family okay?
The family's fine. He lives by himself, actually.
He lives by himself.
He's older, but he does have family in the area.
HIV status?
He's HIV negative.
Does he have any partners?
No, he does not. He's actually not sexually active.
He's not sexually active, okay. So, all right. Christina,
I don't think I have any questions now. Yes.
All right. We'll leave it to our listeners to figure that one out. That'll do it for TWiP 210. You can find the show notes at microbe.tv/TWiP. If you want to send in questions or your guesses for our cases, TWiP at microbe.tv. And if you like what we do, consider supporting us. We are a tax-free 501(c)(3) nonprofit corporation, and we exist on your donations. Go over to microbe.tv/contribute. Daniel Griffin is at Columbia University Irving Medical Center, parasiteswithoutborders.com. Thanks, Daniel. Good to see you here.
Oh, thank you. And thank you to ASTM&H for allowing us to do our podcast here.
Yes, thank you, ASTMH22. We loved it, and we'd like to come back next year and do it again, right?
Okay, we'll just try to behave better next year.
Yeah, we'll have, maybe Dixon can stay healthy, right?
Yes, let's hope so.
That would be nice.
Christina Naula is at the University of Glasgow. Thanks, Christina.
Thank you for inviting me to come along. It's been wonderful.
Came a long way. Hope it was worth it.
Absolutely, every minute.
I'm Vincent Racaniello. You can find me at virology.ws. I'd like to thank the American Society for Microbiology for their support of TWiP and Ronald Jenkins for the music. You've been listening to This Week in Parasitism. Thanks for joining us. We'll be back soon.
Another TWiP is parasitic.